Hi, everyone, and welcome to another IS-PEC Talks. Today, we are honored to host Dr. Donna Shelley. Donna is a professor of public health policy and management and the co-director of the Global Center for Implementation Science at the New York University School of Global Public Health. She is one of the most influential voices in applying implementation science to tobacco control and global non-communicable diseases and HIV care. Her work spans theory-driven implementation strategies, health system strengthening, policy implementation, and sustainability across diverse settings, from primary care practices in the U.S. to community healthcare centers in Vietnam and abroad. Donna, I'm very excited for our listeners to learn from your experience at the intersection of evidence, policy, health systems, and global implementation science. So thank you for joining us.
Well, thank you for the invitation.
So you were doing policy relevant systems research before implementation science was even a thing. There was even that term. So what drew you into implementation science?
Well, I'm a clinician by training, and I was practicing medicine, and then I got a master's in health policy and management, and actually took a pivot to the city health department to launch the tobacco control program. I mention that because tobacco cessation has been my focus, my content focus. But then I went to Columbia to launch my research career because at the health department I was doing some health systems work. Our health department has actually a network of primary care practices that they do quality improvement with. But when I got to Columbia, I was very fortunate that we had a safety net healthcare system. They're called federally qualified health centers in the U.S. You need a site to work when you're doing implementation science in health systems. And I started working with them on implementing tobacco use treatment guidelines. So I have an evidence-based intervention. It's screening, brief advice, pharmacotherapy. So the question is, how do you implement it? And when I went into the sites, and sort of thinking about organizational theory, there's a whole field of organizational theory and administrative theory that my colleagues in that field have told me we have our own theories, but this was really pragmatic research actually, and you're working in someone else's backyard, and there's time limits. And the question I realized was that I knew what the evidence-based intervention was, but what we were doing was implementing the evidence, and I didn't have the terminology or the frameworks or the language to actually think about, well, how do I define those? What are those things? They ended up being strategies, implementation strategies. But I started, as I was reading the literature, this field started emerging. And I actually went to the first conference and I felt like, oh my gosh, this is my home. They're talking my language, they're providing me with the methods, the tools, the frameworks to actually answer the key question, which wasn't, does this intervention work? But how do we get this intervention into practice? And so that's really how I got started. And the biggest problem with not having that language is that you really can't evaluate what you're actually doing. And you actually can't replicate it in other settings. And so I think I was drawn to it for those reasons. There was nothing at the time, I think, really that I think improvement science has actually evolved. I think quality improvement science and healthcare system science, which sort of grew up in the Veterans Administration in the U.S., has evolved to become also a much more rigorous science. And you're seeing improvement science and implementation science actually coming more together in terms of sharing methods and terminology and frameworks.
So just 2 points for clarification. When you say the first conference, you're referring to the NIH conference.
Yes, I'm sorry, the Dissemination and Implementation Science Conference, which literally had 100 people. And now has over 3,000 people joining. Just moved to a larger setting recently. For this next meeting, yes. The Dissemination and Implementation Science, which was launched by NIH, but now is actually hosted by the Academy of Health.
Yeah. Okay. So when I was there, they were co-hosted, but okay.
Mm.
And when you talk about the language, I think something else that you didn't mention is that it's not just that you don't know. Even you needed the language to measure it, but it was also you needed the language probably to learn from others and see what others have done to see what is applicable to here. Because once you don't have that, if you don't speak the same language, you can't share. Yeah, right.
Right. And I think it was helpful to the clinical leadership too, to sort of start to say, instead of measuring, well, did you actually are you delivering the treatment? It's like, well, how did that all happen? and they were trying themselves on the ground. I mean, these health systems were, they're monitored by the federal government. They have to send metrics to the federal government, and they were trying to do quality improvement, but it wasn't really, it was a little bit, it wasn't systematic in approach. Right. And so they were feeling lost. At the time, actually, learning collaboratives were a big thing, which is a strategy, sort of a meta strategy for trying to improve quality of care. But the sites that I started working in felt like it didn't actually change the set. That they would send someone to a learning collaborative, and then they come home and they would be bogged down with their own research and their clinical work, and it didn't change that site, the system itself. And so, just as an aside, I became very active and interested in something called practice facilitation, which was also born in the VA system, which we could consider a meta strategy, because it's this idea of supporting sites through helping them update their electronic records, training, capacity building, etc.
Okay. So you did that in the U.S., and then you made your way to Vietnam. How did that happen? And tell us a bit about that.
That's a great lesson for your trainees and students. Is when I was at Columbia starting my career, I got very fortunate that I was handed an amazing doctoral student because he was unhappy with his mentor. And I had a career development award at the time that I had received as one of my first grants. And he was Vietnamese, and he helped me with this project. We became very close. He moved back to Vietnam, worked for the Ministry of Health for a while, started his own research institute, which is very rare in Vietnam, and actually literally emailed me 10 years later saying, we're ready for tobacco control research. And in fact, the Framework Convention, the WHO had implemented this treaty, and Vietnam had been one of the 183 countries, to sign this treaty, which meant they were starting to implement all kinds of, evidence-based tobacco control policies, smoke-free air laws, media counter-advertising, et cetera. And he was also a physician scientist, and he wanted to work with me on implementing tobacco use treatment in their primary care system. And so that's how I got started. People always wonder, how did people end up in how did you end up in India? How did you end up in, it's oftentimes, a contact like that, someone who passes through your life, who you keep in touch with, which is one of the, take-home messages, is never let a valued colleague leave your, network. Stay in touch, because it has been an incredible experience, and I've learned a lot from it, and it's, been the sort of the primary work there. I've been very fortunate that the National Cancer Institute has been very interested in implementing tobacco use treatment in low- and middle-income country primary care settings. So I'm doing actually a study now in their HIV clinics right now, same thing. But their systems have evolved, so the strategies are slightly different.
That's a classic. Relationships are important, and windows of opportunity are important, and those go together. Wow. So you speak a lot about theory-driven implementation strategies. What mechanisms would you say matter most for moving guidelines and evidence-based practice, as we call it, into routine practice? Especially, we could talk about the U.S., but Vietnam, it's a resource-constrained setting. So what are the challenges? What do you need to think about?
I mean, it's interesting because in Vietnam, it's a communist country, so it's completely top-down, and there's not a lot of autonomy at the clinic level. And there you're talking about policies and funding streams, and, are they going to be offering ongoing training to increase at the individual level confidence, motivation. But I think the thing that's important is, when we think about intervention research, we often think mostly about individual level mechanisms of action. And when you're doing implementation science, it's really the sort of outer setting and inner setting, particularly the inner setting. Oftentimes it's very hard to influence the outer setting, right? So you're working, though, in my work, I've very much focused on that inner setting, the healthcare system itself. And is there leadership? What's the organizational priority? What are the resources that are being made available? what are the systems in place? Does electronic record even have a place to screen for tobacco use? Are there referral resources? Can doctors outsource and send it to a quit line? How would we put that system in place? And then, of course, doctors have to be motivated, but doctors are completely overwhelmed by medicine right now. I don't know what it's like in Israel, but in the U.S., electronic records have actually made it worse. There's a lot I could say about that, but I think when we think about theory and mechanisms of action, the thing about that implementation science sort of helped me understand was the importance of that inner and outer setting mechanisms of action. So what is happening at those levels that matters, and not everything matters. So we often start with a needs assessment of what are the barriers at the outer, inner, an individual level, that both individual clinicians and patients level, and that patients are often forgotten in the consolidated framework for implementation research model because everyone was so focused on the providers, but the patients matter too, and what they think and what they believe and what their motivation is and their confidence and their belief system. So I think it's not really a simplistic, it's not a one-word answer, what is the mechanism? Of course not. We're talking about implementation.
Right.
But I think this awareness, but I don't use a laundry, I don't look at the C4 framework and say, oh, I'm going to measure all of these different mechanisms. I think you have to think with your partners, and that's why this sort of formative work is so helpful to sort of understand, well, what are the levers that need to change? What are the mechanisms that are creating barriers to implementing tobacco use treatment? And how do we develop strategies? That strategies are theory driven in that sense to actually address those specific barriers.
So you spoke now in your response in terms of more the inner circle, but so I just spent an hour, and we have monthly meetings with IS-PEC with all the students in Israel that are studying implementation science, policy engagement, not just the ones at Ben Gurion University. So it's open to all students. And we discussed the 2023 article, which we'll link in the show notes, that Jonathan Pirtle and you wrote about how to integrate not the inner, but the outer circle. How do we think about policy and implementation science? And you had 4 different approaches, which I loved. And one of them, I thought, oh, that's such a smart way of just, think of policy as the external context. That's it. You're not, the purpose of this is not to change the policy, but the policy is the given. Now, how are you going to implement the evidence-based practice or whatever? So,
right.
So how do you, what's the next step of this article? Or, how would you take this forward to the next, in terms of your training students and, you're teaching them to balance between policy and implementation science, and they may say, okay, so I actually want it to be the first relationship that they talk about in the article, that I want this research to impact the policy. So how do I get to the policymakers? How do I get a seat at the table? And, the classic answer is, well, bring a chair and then you'll have a seat at the table. But beyond that, so, what advice would you have for students based on this article?
What I would say is all politics is local. And so, we have we're a federalist system. So if you want healthcare policies to change, you work at the state. I've been working at the state level. I would say that I would say this, that, early on, I was very lucky. 25 years ago, I got a contract from the New York State Department of Health's Tobacco Control Program. And the contract, which I've had for 25 years, was to implement and disseminate tobacco use treatment guidelines in safety net systems across New York City. So this has been my learning lab, my laboratory. And
25 years, the same contract. Yeah. Wow.
Yes. We just submitted again for 5 years. We're the only state that actually has continued funding at this level, tobacco control. But to have this funded, this piece of it is none of the states do this. So I've been very lucky to be in New York State, which is also ahead of the curve in tobacco policy. So in doing that, we started realizing, so I've worked at both. I think that paper is really interesting also because you can see how, one of the policy, I'll give an example. So there are 7 medications for treating tobacco, nicotine addiction. But Medicaid didn't cover them, actually, which is the state's insurance, right, for people who don't have resources. So one of the things we lobbied for at the state, so at that time we're talking about policy dissemination. So we're talking to the policymakers saying, we need this covered. You need to add this to the Medicaid coverage. And what was interesting is states, what I learned from this experience is they did what we wanted them to do, but they didn't talk to us about how they defined that policy. And so what they did was they required, and I know we don't have a lot of time, so I'll make this quick, is that providers, healthcare workers had to write a prescription for all of these, even though 3 of them or 4 of them were over the counter. Why is that a problem? Because they don't know how to write that prescription. And so when we started going in promoting that this Medicaid benefit was available, the response from them was, Donna, I mean, we haven't written a prescription for this. It's been over the counter for 25 years. And we don't even have, how do we even do that? So then it became sort of how do we, this is, finance, this support is also a strategy, right? How do you increase access to treatment? You make it free. But how do you implement that? I'm sorry to say, that's the evidence-based intervention is this financial, making it free, this finance approach. But then how do you implement it? And I think, policymakers don't really think about that. They say, okay, God, I gave you your policy. What do you want from me? And we were sort of saying, wait a second, but luckily they had us on the ground. We gave this feedback to them. They didn't change that, but then we actually started creating prescription pads. This is before electronic records, by the way. We started, and we've evolved, but we had to implement that policy. We had to create strategies so that evidence-based policy, free medication, could actually be implemented so that patients could benefit from it. So, I think it's, I've mostly been at the implementation, sort of stage of policy. They also started reimbursing doctors $20 for doing counseling, tobacco use. That was another policy we wanted. But I won't get into that policy was also at the last minute. They made it only for people with behavioral health problems. And, the doctors were saying, are you kidding me? I mean, we have to now create a new system. How do we even identify those patients? We have to create something separate, create a whole database of only people with behavioral health problems to give tobacco use treatment to. So, when it's a lesson sort of when you're working with policymakers and saying you want this policy, it's also helpful to actually define what you think will be the most effective policy and that can be a policy that makes sense in terms of implementation at the back end. And I don't think those two fields, policy dissemination and policy implementation, have been really separate. I mean, it's great having Jonathan Pirtle in our world, in our center, because it's been really fun being able to sort of merge those two and really understand, that framing of the policy itself starts with the dissemination process.
When you were describing how they don't have a way to prescribe it, on the one hand, my immediate reaction was, I'm just going to hit my head against the wall. It's so, but on the other hand, but that's such a quick fix also. It's just a matter of communication and understanding what the issue is. And then, okay, we could fix it easily. So no need to hit your head against the wall, just keep talking.
Right. But because we were there, I mean, there were, again, we knew what this evidence-based intervention was, this policy at the time, but we were able to take our implementation science lens and apply it by saying, okay, we can come up with some strategies to make this simple for the doctors to do. Again, I learned a lot about, okay, be aware of what you wish for, make sure it's actually what you want and need, and it's feasible to implement.
So a final, you talk about what you learned. So a final, we always like to leave our listeners with, a piece of insight, a piece of advice. What is the younger Donna Shelley, before she got the 25-year contract, or before you got to, to New York State, et cetera, what do you wish you would have known? What's one piece of advice that would really help our students before they start on their journey?
I think being humble is really important, because you're working in other people's settings, and respect, understanding that bi-directional learning is critical, and to acknowledge that you have something to learn. This is, it's not just in Vietnam I talk about cultural competency too. When you work in a foreign country like, Vietnam, it's obvious that you're not culturally competent in that environment when you first start working there. And I
Probably
may
even
never,
after you first start working there, probably even 10 years later.
well,
You're
I would
not.
say that I still consider myself culturally incompetent in terms of Vietnam. Always learning, but being humble has been really helpful. And also just respecting and understanding that there's opportunities for bi-directional learning. We talk, that's all over the literature, bi-directional
Yeah.
learning. I don't know that we really defined how we do it well, but I keep that word in my head all the time because I want to always, again, be humble and understand that I'm learning from the people I'm working with. It's their world, it's their settings, it's their policies, and they're privileged to be a researcher in that environment. I would say building a network. I came to research as an older person, and so I was already had some more confidence. I've run the tobacco control program, but I think I see, I often tell early career faculty, build your network, and use your mentors to do that, and never and sustain those networks. I mean, I'm still in touch with people because people come back around in your life too, all the
Look at your
time.
student from Vietnam,
Yeah, I
right?
mean, and so like maintaining connections with people. I still am in touch with my research assistants. They email me as they're moving through their career. So building a network, and again, identifying mentors, and mentors are forever. Even at my age, I still seek out mentorship. So sort of network building, mentorship, but also this idea of being humble and understanding that you know. Even in New York, my first grant was actually in the Chinese community. So I was trying to understand, like becoming culturally competent in my own backyard was really important.
Right. So I love it because so many times when I'm in meetings, I'm not a clinician. And most of my work is obviously in healthcare. And I go into meetings and I say, I have no clinical background. You need to tell me what the thing is that we need to implement, and I can help you implement, but I'm not a clinician. I'm not a this. You may need to be the one that, it's your idea, you're pushing it. And they look at me, they're like shocked. Where's your ego? Where's your, and I'm like,
Yeah.
no, I don't know anything about tobacco control or benzodiazepines or whatever intervention we're working on. No, I don't know it. You are the expert in that. I'm going to learn from you. And then, okay, so your pieces of advice are being humble, bi-directional learning, building your network, sustaining your network, and always seeking out mentors. I think those are all very important pieces of advice. So thank you, Donna. I think we have a lot more to talk about. We may be doing a version 2.0 at some point, but thank you so much for your time. Greatly appreciate it.
Okay, thank you, Moriah, for the opportunity to speak with you today. Okay.